This is a quick review on how to do an assessment for threatened preterm labor, so labor happening before 37 weeks. So a couple of things to remember before I get into sort of more discussion about the assessment is quickly STAT, which is steroids, tocolytics, antibiotics, and transfer. So steroids help the baby's lungs mature. Tocolytics quiet the uterus and slow down the labor to give the steroids some time to work. Antibiotics are going to prevent infection, and you want to transfer the woman so she gives birth at the best level possible, so at a hospital that can manage the care for the baby. You always want to start your assessment with a speculum exam, so not a vaginal exam. You don't want to do a vaginal exam until you've ruled out ruptured membranes. So if the woman is ruptured, there's a lot of curiosity and you'll be asked several times to do a vaginal exam, but you need to confidently describe the cervix that you saw when you did the speculum exam. So unless she's contracting, a vaginal exam is contraindicated. So until you've ruled out ruptured membranes, or if she is ruptured, you do not want to do a vaginal exam. And that's because, for example, if she's 32 weeks with ruptured membranes, they'll keep her in Montreal for 2 weeks to try to help the baby mature and buy some time. And you don't want to have introduced your fingers, introducing her risk and increasing her risk of infection. So you only do a vaginal exam if you've ruled out ruptured membranes, or if she's ruptured but there's regular contractions. So now you're thinking those contractions are causing changes to the cervix. So you do the vaginal exam to determine if you can still give tocolytics to quiet the uterus, and I'll talk more about that in a minute. You want to decide if she's suitable for transfer or is she getting close to delivering. And also, at the time of birth, you want to assemble the team. So you want to know if the baby's coming in a minute and then have the team ready in order to receive the baby, because the baby might need extra help. Also, just to keep in mind, something that's new is the guideline around neuroprotection. So we give magnesium sulfate IV to the mother about 4 hours prior to the birth. We discontinue tocolytics, but the guideline has changed, and now it's 33 weeks plus 6 days instead of under 32 weeks. So doctors might not know that there's a neuroprotection guideline change in the last year. Okay, so I have a diagnosis of a threatened preterm birth if she's less than 37 weeks, she has regular contractions, and these contractions are causing the cervix to change. So that's my diagnosis. I'm going to do my assessment. And feel free, if you're a nurse in the village, feel free to call the midwife on call in Kuujjuaq, because even though this woman is not our patient, she's the doctor's and yours patient, we can help you organize the assessment in order so that when you do call the doctor, you have sort of you've already done a lot of the things that they're going to ask you. And maybe we can talk you through some of the more difficult things. So first of all, you do an abdominal palpation. So you want to determine if the baby is head down or vertex. A baby that's head down, you can feel a little apple. So the baby's head feels like a little apple right above the pubic bone. And then with your other hand, your left hand is on her fundus. It feels like a wider part of the baby, and you're holding on to the hips. So if you feel like a wide part in the fundus and a little apple above the pubic bone, probably the baby is head down. You also want to assess the cervix, as I said, with a speculum exam, and you're going to visualize the cervix. You're going to do it just like you do a pap test. You may ask the woman to put her fists under her bum to sort of tilt her pelvis up towards the speculum. And you're going to visualize the cervix in the speculum, and it should be hopefully closed. A cervix that's starting to thin and open, you may see a little bit of baby hair in the opening. You may notice that it's thin versus thick. Those are all things where you can describe those changes to the cervix when you call the doctor. Then there's 2 tests that we can do. They're bedside tests, and I'll explain them more below. But there's amnisure, which tests for the presence of amniotic fluid volume in the posterior fornix. The other one is actin partis, and it tests for something called insulin-like growth factor, and it's done within the cervix while you're doing the speculum exam. And you'll have those results in about 5 minutes because it's right at the bedside. While you're there with the speculum, do swabs. So you're going to test for chlamydia, gonorrhea, any sort of yeast, and then, which isn't super important, but also group B strep. And order those tests, because if the baby is born preterm, then we have those results to know if the baby's at risk of certain infection. If their membranes are intact, so they're not ruptured, the amniture test was negative, and you've checked her 20-week ultrasound and you know that her placenta is far from her cervix and not marginal or placenta previa, you can do a vaginal exam. You want to describe, is the cervix posterior? You have to go quite deep into the pelvis and reach around to get to find the cervix, or is the cervix right there when you put your fingers in? Then it's midline. You want to know, is the cervix soft or firm? A firm cervix feels like the end of your nose. A soft cervix feels like your lips. You want to know, is it open? Can you put your fingers inside the cervix? And then also you might notice like it's paper thin or it's thick. So those are all things to describe. So position of the cervix, so posterior or midline, is it firm, is it soft? Is it starting to thin? So is it paper thin or thick? And is it starting to open? Can you put your fingers inside? That's sort of intro to vaginal exams. The other labs that you want to order while you're there is FSC, so a complete blood count, a group screen and cross match, as well as a urine culture. So we find that so women who have a bladder infection, it can cause a lot of pain in that front of the suprapubic area, and it can cause a lot of uterine irritability. So we don't want that infection to quickly blow up into her kidneys, causing pyelonephritis and tipping her over into preterm labor. So also think about bladder and urine infection. As well, you want to do a fetal heart. So normal fetal heart rate is between 110 and 160. There shouldn't be any decelerations below 110. Only sometimes if the baby's coming quickly, then the head gets squished and you might get a bit of a deceleration. You also, for transfer, consider a Foley catheter because she'll be more comfortable if her bladder is empty and she's contracting. So there's no way for her to pee on a little airplane when she's moving from village to Kuujjuaq, as well as from Kuujjuaq to Montreal by Challenger. So going back to management, you start off with steroids, tocolytids, antibiotic, and transfer. So with steroids, it matures the baby's lungs, and it's indicated for 24 to 34 plus 6 weeks. And the first choice is betamethasone, also known as Celestone, and the dose is 12 milligrams IM Q24 hours for 48 hours. So the way I remember that is that it's alpha first, choice is beta methasone, also known as Celestone. So ABC, and 12 milligrams IM Q24 for 48, 12, 24, 48. It's contraindicated if there's TB, gastric ulcers, be careful, chorionitis as well, judiciously use. And if she has type 1, 2, or gestational diabetes, it could really spike her blood sugar, so to be aware of that. So the steroids take about 48 hours to work to help the baby's lungs mature. So we're trying to buy some time by quieting her uterus. So if she's less than 4 centimeters dilated, we can provide her with a tocolytic, and it's going to quiet the uterus. However, it can cause a blood pressure drop, and so we bolus her with 30 mils of normal saline prior to giving it to her. If her blood pressure drops, you're going to have a drop in the fetal heart rate, which is a bit scary. So don't do that. So you can give her fast-acting Adalat, also known as nifedipine, and we start off with 30 milligrams PO-stat. And then you're trying to titrate the nifedipine to get it so that she's kind of basically going contractionless for the transfer. If she's less than 32 weeks, you can also ask for indomethacin intrarectal for the transport. you want to know that she's 32 weeks confirmed and not actually 34 weeks. So she should have had a T1 ultrasound dating, and you shouldn't have questions about her due date if you're going to do this. It can cause a bit of a complication at the birth for the baby in terms of heart, patent ductus arteriosus. So antibiotics are not indicated if she's known GBS negative, if we were swabbing her early, and if her membranes are intact. So antibiotics are only indicated if she's known GBS positive or prolonged rupture of membranes. It's not indicated if she's GBS unknown. So SOGC recommends you treat just as for GBS at term. So prolonged rupture of membranes or GBS positive. So with that said, we always seem to be throwing antibiotics at them, and so there's no penicillin IV in the village, but they stock ampicillin 2 grams IV, which you can start in the village, and the midwife comes with erythromycin in her medevac bag, and so those two used together is given. In terms of transferring the baby, if you're in the village and the baby, say, is born at 36 weeks, you still transfer the baby. Even if the baby's fine, the mother's fine, you still transfer the baby to Kuujjuaq because that baby's going to need additional monitoring for the first few days, if not weeks of life. And so that can only be done in Kuujjuaq. For Kuujjuaq to Montreal, all babies less than 34 weeks or babies under not really 37, probably more like 36 weeks if we're short-staffed, we transfer to Montreal, or if the team presently in Kuujjuaq is super inexperienced, or if there's obstetric complications. Any baby who needs supplemental oxygen, can't maintain its temperature outside of the incubator, has trouble with hypoglycemia, apnea spells, those babies need to go to Montreal. We only keep babies over 34 weeks if all they need to do is fatten up and possibly a little bit of light therapy for hyperbilirubinemia. Those are the only babies we keep. Okay, just a few notes about magnesium sulfate. We rarely use this, but just to note that in 2020, the SOGC changed the guidelines from 32 weeks, and now it's indicated at 33 weeks plus 6. Some doctors may not know this. So usually we would be consulting with an obstetrician down south. You discontinue the tocolytics, and we're thinking the baby's going to be born in about 4 hours or more. And we start just as if with preeclampsia. So 4-gram loading dose over 30 minutes, and then a 1-gram maintenance dose infusion until the birth, up to 24 hours. Hopefully we've gotten rid of her by then. And you're going to monitor as per preeclampsia. So her reflexes, respiratory rate, alertness. Magnesium sulfate makes the woman very tired, but you can still rouse her. So it's not unusual that she kind of drifts off to sleep suddenly, but you can still rouse her. She should have on continuous fetal monitoring because we're in Kuujjuaq. We have a machine that can do that. And when the baby's born, be aware that it could be a cause of hypotonia and apnea. So the two tests done in the village or in Kuujjuaq that we can, I just go into more detail, those are the tests that we're going to do when you use a speculum to do your first assessment. So AmniSure tests for, is her membranes ruptured? Actum partus tests for, is there a chance she could go into labor? So it's a bedside test. We do it with a speculum, and with the AmniSure you do it in the posterior fornix, but you can't use any lubricant. It's okay if there's some semen or a small amount of blood present, and you can do it at any time. You can do it at term or preterm, and it's very accurate. Also, the woman's going to tell you a story. Did she have a big gush of water, or it's been a slow leak? There's a leak or gush every time the baby moves, or she has a contraction. Those are all sort of indicative of ruptured membranes. Actum partus you do in the cervix, so it's a swab in the cervix. It is accurate in the presence of lubricant or semen, and you can use it anytime over 32 weeks. It's 50% sensitive, which means that if it's positive, there's a 50-50 chance she's going to go into labor. But we're going to transfer her because we welcome that information. If it's negative, we're 98% sure she will not go into labor in the next 7 days. this is this has been a game changer for us because in the village people present late because they think any whiff of a contraction the nurse is going to send them south. And so what you want to do is do your education prenatally about signs and symptoms of preterm labor and invite them to come in, and we could do this test and they could be home within an hour, and we don't need to worry that they're going to be transferred unnecessarily. So that education taking place in pregnancy helps women come in early, come in for an assessment early, and that gives us time that if she is in labor, we can transfer her either to Kuujjuaq or south, so that the baby has the best chance.